It is my pleasure to announce our final speaker of the day, Dr. Kevin Hagwald. Dr. Hegewald completed his medical school in Eastern Virginia, then did his residency in Southern California. That's where I met him. I was the lowly intern, and he was the chief resident. And he wowed me with his Envenomation knowledge. He's speaking today on Envenomations, What's Biting You. He still lives in San Clemente, California, where he lives with his wife and 4 children, and then does shifts as well at Intermountain Medical Center. He jokes that he lives on the beach and plays in the mountains, so he has the best of both worlds. So please help me welcome Dr. Kevin Hagwald. He has a handout, too, so we'll be passing those out.
Thank you. Good afternoon. I know I have the seasoned hardcore clinicians here. Either you're really into insects, bugs, and snakes, or you really are into medicine. And I hope today, with the late hour, that I can leave you with a clinical resource. Actually, Dr. Housen's passing out right now. This 3-page, I don't believe is in the CD. This should provide you everything you need to clinically treat the envenomations pertinent to the Intermountain West, to all of the western United States. So to get us started, though, I was told by Dr. Housen I could tell you this story. It's a pertinent one. Let me see here. I guess I'll have to fly free here. Do we have notes? This story involves a man who was in general good state of health, who had terrible back pain for absolutely no good reason. And this back pain persisted. He went to physical therapists. His doctor was given pain medications, changed his shoes, changed his mattress, and this terrible back pain persisted. He finally found one clinician that had an answer for him. It was a surgeon, and the surgeon offered him the solution, which was basically, we need to incise, we need to cut out your testicles. And this poor soul was like, you're going to cut off my testicles for my back pain? You got to be kidding me. So he persisted further. The back pain continued to be terrible, terrible back pain. Finally, he said, I can't live this way, and he relented. And he went to the surgeon, had castration performed. The next day, post-op day 1, his terrible back pain was gone. And he was like, wow, this really worked. To celebrate his new life, he said, I'm going to go get me a 3-piece suit. I don't have my testicles, but I can live. I have no back pain. He went to one of the finest tailors, and the tailor checked him out. This was a good tailor now. He sized him up and said, sir, you're a size 15 shirt around the neck. You got a 35 length sleeve. Your shoe size is size 11, and your undergarment, your underpants size is a size 34. And our patient, whose terrible back pain was now gone, said, wow, that's really amazing. He said, that was right on, except I wear a size 32 undergarment. And the tailor said, no, you wear a size 34 undergarment. And they had this little discussion, and finally the tailor said, look, if you wore a size 32 underpant, you would have terrible back pain. And so as thinking men and women, we have to ask ourselves, do we engage in serious invasive procedures, or do we simply change our underpants? And this is so pertinent for today's lecture on Envenomations. We'll come back to that again and again. Let's see here. Or freeze frame. Here we go. So something that probably would require more of a serious invasive procedure. These are just little eye candy here for us all. This is the Sydney funnel web spider. This thing is gnarly. Its fangs are 4 to 5 millimeters in length. It can pierce the skull of a chicken or the fingernail. When it bites, it hangs on, and its venom is known to be lethal. It's found in Australia. Luckily, this is something that we don't have to deal with. This is something that would require more serious invasive procedures that we as clinicians would maybe have to delve into. But fortunately for us here locally, it's more of just an interest, something that maybe keeps us up at nights. Now, these creatures here are tarantulas. We have tarantulas in the Intermountain West. This is probably something more just to change your underpants about. I mean, they look scary. They're very furry. They have a lot of urticating hairs that they can flick that cause a lot of allergic problems, especially if if landing in the eye, as we've learned in our last lecture, there is an envenomation eye connection, and the tarantula with the urticating hairs can create terrible keratitis of the eye and blindness. But other than that, these are simple, soft creatures. They make great pets. They rarely bite, and if they do, it's just a very local effect. This creature, however, is something different. This is the fer-de-lance found in Central and South America, also known as the equus spider because of the markings on the back which create an X. I wasn't able to entirely confirm this, but this is an 11-year-old boy who was bit by a fer-de-lance and was treated kind of in the bush with antibiotics. And 2 weeks later, he presents with, obviously gangrenous changes of the leg. He's going to, he loses this leg. It has an AKA performed, but very sad. The fer-de-lance is such a powerful venomous rattlesnake viper that it was used in the earlier antivenoms that were available. This is the Wyeth antivenom that's no longer used in this country, but it's interesting. This little packet here was made for the lay person to take out into the bush in the event of an envenomation. You'd actually even do a skin test because it is a horse serum-derived antivenom to make sure there's not an allergic reaction, and then you would inject your victim. Unfortunately, we've come a long way from that kind of treatment. Here's another creature that you should just probably change underpants with. This is the rock scorpion of South Africa, and it's interesting, scorpions, the bigger the body, the less the sting. And you can see here this is a very big-bodied scorpion, has a very small stinger, and all scorpions fluoresce, which I think is really interesting. But we'll talk about the scorpions that are native to our region and which ones we might have to worry about. And lastly, the infamous Gila Monster. So much mystique, so much misperception, surrounding the Gila Monster and the bearded lizard. The beaded lizard, both of which are venomous. Good example of a creature that has pretty powerful venom, but very poor venom delivery. This is a creature that you would have to let gnaw on your fingers or toes for a while in order to get envenomated. So if anyone gets bit by Gila Monster, they're probably trying to. Not something you're going to see in your clinical practice. So from here on out, I'm going to try to keep this very clinical with some eye candy. And I hope that you can take home, and you don't have to take notes because those 3 pages truly give you everything you need to become an expert. And I will say that if you're a frontline clinician, it's really important that you dial yourself in with Envenomations because the inpatient services historically have not known as much or have had to deal with as much as maybe a primary care or emergency setting clinician. So you will really be the expert for Envenomations. So this is a really interesting event here. This was a dispatch by the CDC in their Morbidity and Mortality Weekly Report in 2003 about something going on in the jail. And you can see these lesions here. There's some grouped pustules and then this big indurated lesion on this gentleman's cheek. And the CDC Public Health Dispatch warned of an epidemic of skin lesions in the Los Angeles County Jail among the inmates, thought initially to have resulted from a spider infestation. So there was these attacking spiders, right? Swarming spiders on these poor inmates. I mean, they've suffered so much, and now the spiders are attacking them. Well, we all know what this is, correct? This was 2003, and this was one of the earliest advents of community-acquired MRSA cellulitis. But the stigma of spiders continues, and we're going to start with spiders because they're the smallest of the wee creatures that we're going to talk about today. So when you think about spider bites, and the differential diagnosis with spider bites. This happens to be a hobo spider, which is a spider we'll talk about a little bit more. You can see these V-shaped markings on the dorsal aspect of the ventral of the abdomen, chevron markings that identify the hobo spider. So with arachnidism, you think about solitary lesions and a solitary victim. There are no swarming spiders, except maybe in Hollywood. You always like to see maybe a little bit of an identification of a spider, maybe a little leg or some body parts. You think about immediate local pain, which is true for almost all spider envenomations, except for the one that's probably the most important, which is the black widow spider bite, which we'll talk about. And the black widow spider bite is well known for its neurotoxicity. This in comparison to cutaneous or insect bite infestations, you're going to see multiple lesions, multiple victims. Think about the correct setting. With community-acquired MRSA, we think about jail or institutional settings or military barracks or colleges and university settings. You think of the burning and itching and a slower onset of pain, and then again no systemic findings. So I think that's important just from the get-go to kind of set the stage for spider envenomations. These are not swarming creatures. They oftentimes will be found, a solitary bite might be found in a constriction point of clothing, such as the waistband, or maybe around the neck where the little critter might get caught. And, it's a defensive bite, right? It's trying to get away from you. It can't, and just before you squish it gives you a little bite. So when we talk about epidemiology for spider bites, there's many, many species. They continue to define more and more species of spiders. We talked about the no swarms, the defensive bites only. According to the American Association of Poison Control Centers for Utah, for the last 3 years, 2008 through 2010, there's only been 245 reported bites. You know that this is grossly underreported. There's certainly many more bites. And of the 245 bites reported, 200 of them were black widow envenomation. And again, I think that's because the black widow envenomation gives you many more symptoms than just a little local lesion, which might go unnoticed or not be taken very seriously. And so the three spiders, and this is a little contested, but there are three spiders of medical interest for us in the West. The first is the black widow spider, or widow spiders, and I think you should frame it as widow envenomations because all widows are able to envenomate. And there's the classic hourglass sign, a red marking or a yellow marking. We'll talk more about that. The second notorious spider that we'll talk about is the brown recluse or the fiddleback spider. You can see this. I hope you can see or appreciate that fiddle or that violin-shaped marking on the back of this critter. And then the last one, which is kind of new and a little controversial, would be this hobo spider. And you see again the chevron-shaped markings on the back of the abdomen there. When we talk about spiders, I'm going to group them up to local effects and those which cause more systemic. So first of all, let's talk about the hobo spider. This was thought to be brought across from Europe and landing in the Pacific Northwest, and it's really kind of found a home in the Pacific Northwest. You can see here in red Oregon, Washington, Idaho, and tracking into Utah seems to be the home of this spider. It's difficult to identify. The one consistent mark that you find would be these chevron markings. There's a lot of opinions about the toxicity and the aggressiveness of this spider. The European literature claims that the hobo spider is very non-aggressive, and yet in our country, the claim is that they are aggressive and that they can cause medically significant lesions. And I think this is important too. We talk a lot about spider bites and brown recluse bites. We're far from the native territory for brown recluse, and this might explain why we see what looks like a recluse bite outside its home range. And the hobo spider is going to cause dermonecrotism, very similar to the recluse, which is with local erythema, induration, and it can progress. It's considered to be not as bad as the recluse, but still medically significant. So the hobo spider, this might be a new one that you haven't heard of before, and it is fairly new, meaning in the last 20 years it's really established itself in this country. Now, some authorities feel like the yellow sac spider should also be considered medically significant. Same thing, not important so much to identify what kind of spider, but this idea of dermonecrotism causing an ulcerated lesion that can be very cosmetically scarring. The hobo, the yellow sac, and the brown recluse. The brown recluse spider, or recluse spiders, genus Loxylles. This picture shows you their homelands. There was one report in Kansas of a home that was infested with over 2,500 brown recluse spiders. So they can be transported and kind of take up shop in a community, but typically those would be isolated events. Here's our friend, the brown recluse, the classic fiddleback. And this would be a very classic skin lesion, probably 1 or 2 days from the time of envenomation. And we'll talk a little bit about this. They call it the red, white, and blue sign. And you might appreciate on the very outside of this lesion, there's kind of a serpiginous line of redness. And right inside that, there's this area of blanching or white or ischemia. And then more centrally, you get kind of a purplish bluish, giving you the red, white, blue. This would be a classic finding for a recluse spider bite, and it represents just this amazing toxin that the brown recluse spider create, which causes lots of local tissue damage through enzymatic degradation of skin and adipose tissue, but also it activates our own immune system, and our own immune system wreaks havoc on this kind of lesion because it recruits so much of the complement cascade and so many white cells, causing vasospasm and ischemia, worsening the lesion. Again, these may live outside their home range. Think about the dark violin-shaped spots centered on the thorax and the red, white, and blue sign. Systemic signs and symptoms for this spider are much less common, although they can happen, especially in the young. There can be renal problems, hemolytic anemia, so that's something to consider. Now this is interesting here. This is a series of pictures. This is day one of what was thought to be a brown recluse spider bite. And I would think as a clinician, if we saw this kind of lesion, you wouldn't be thinking this is a mosquito bite, or it doesn't really look like a cellulitis as well. There's something going on here. You can see that there's deeper tissues involved with the hemorrhage and this kind of this swirl pattern. You see some ischemia, you see some purple, you see some red. So hopefully that would kind of trigger you that, hey, this is more than a little localized cellulitis. This is day 3. Now this patient took pretty good care of this wound. You can see oftentimes a brown recluse spider bite will result in a big eschar formation, a thick, dense eschar that needs to be debrided by plastic surgery. But this gentleman took good care of it early on with wound care, and you just see this open, kind of deep-based ulcer with adipose tissue. And then you can see the surrounding erythema and maybe even some white ischemia. This is day 9, again with wound packing. And this is a big injury for this individual. You can see that there's some death going on, and the packing's taking care of, again, the majority of the fluid and the scar that would typically form. Ultimately, this patient was skin grafted. And then this is 1 year later. You can see this pretty amazing scar that has resulted in this wee little creature. And, that's what's so interesting with envenomation is that a very small amount of liquid, we're talking drops of liquid, can cause pretty impressive results. And none of the venoms of these creatures that we're talking about today are very well understood. They're truly a mixture of many different enzymes. So in regards to treating necrotic arachnidism, or dermonecrosis caused by spider bites, I want you to think about it. Who cares about the spider, but you're thinking this is a spider envenomation causing dermonecrotism. So think about blood and urine studies. Certainly if it's a young person or someone with comorbidities, maybe they have renal problems to begin with. Think about checking blood and urine studies, looking for myoglobinuria, looking for renal failure, looking for hemolytic anemia. It's really mostly about local wound care. Of course, tetanus and antibiotic prophylaxis would be appropriate in most of these cases just because you have such a large piece of skin missing, a large exposed area that could potentially become infected. We know that spider bites don't, from the start, cause infection. That doesn't happen. The portal of entry for all these envenomations are so small, but when you have so much tissue destruction, then antibiotics become appropriate. And then delayed debridement and plastic surgery consultation. I think early on this would be a good thing to do, certainly medical legally, to ensure that proper treatment and the best outcome will result from these locally devastating lesions. And then you may recall, or maybe this is new for you, the medication Dapsone, kind of out there. It probably doesn't hurt. It could help. It doesn't hurt. I would suggest you consider this. Dapsone helps reduce the immune response, our own body's immune response, reduce the amount of leukocytes that accumulate around this wound. And then there has been some fairly good literature, not very rigorously studied in controlled trials, but a lot of case studies about hyperbaric oxygen for these wounds. Again, probably is not going to hurt, can only help. So those would be 2 things specific to necrotic arachnidism that you should be considering. Okay, so let's talk about the widow. This is by far the most famous, the widow spider. She's been around a long time. She's found worldwide. I think if you're really freaked out by the spider, the only place you can live in safety would be Alaska. This last picture here shows a female black widow, and then her male counterpart. It's a little bit of a folklore that the ladies bite the heads off the males after mating. But it seems like every time we talk about this, the women always seem to think that's a really neat thing. I'm not sure why. But certainly the size difference is there. And the reason why the female black widow is more dangerous than the male or the other widow spiders, there's many other widow spiders not of the same size, it's about venom delivery. The toxins are equally potent, but venom delivery for the larger female widow spider is much more effective in causing harm to humans. Worldwide distribution. The red hourglass marking is classic. They can also just be simple little dots. They can have orange or yellow colorations. These are always found on the ventral abdomen. And the body style of the widow spiders are fairly consistent among all the different widows. The black and the brown and the other widow spiders all have that globular abdomen, kind of a glossy look to them. And then here we'll talk about the neurotoxins of the black widow envenomation, meaning very minimal local effects, oftentimes not much felt at the bite site, and all widow spiders can produce neurotoxins, okay, even if it's not a black widow. So depending on how deep, if it was in an area of skin that's very thin, for whatever reason, a smaller widow spider can cause problems as well. The clinical presentation for a widow envenomation, classic widespread sustained muscular spasm. And we think about big muscle groups being involved, chest pain, abdominal pain, back pain. Hypertension, very classic for the black widow envenomation. Autonomic and CNS dysfunction includes bronchorrhea, tearing of the eyes, kind of almost an organophosphate type picture, sludging with salivation and lacrimation. And then again, the local reaction is very minimal. And I can't claim if this slide here of this finger is truly a black widow spider bite, but it helps us remember very little local reaction going on. Let's talk about treatment for the widow spider bite. Have any of you treated widow spider bite before by raise of hands? I've got a few. I would think this is probably one of the more common envenomations that we'll all run into in our practices. It's really about pain control, using opioids, benzodiazepines for muscle relaxation. You're treating them symptomatically. We're going to talk about who gets admitted based on the most recent literature for black widow spider bite. And then there is antivenom, IgG-based antivenom, that's very effective for those who are sick. So who gets admitted? So the high-risk patients would be those who are symptomatic, who are both young or hypertensive to begin with, or pregnant. And if you stick to that rule there, if you can remember that, I think you're in good care, good hands. And it's a little vague as to what it means by hypertensive. I would suppose if a patient's hypertensive, even after controlling pain, and it continues to be hypertensive, that might be reason to admit overnight as well. In terms of antivenom, they talk about respiratory arrest, seizures. That's pretty much no-brainer, right? These are sick patients. Uncontrolled hypertension, and again in pregnancy, antivenom is indicated. And usually the Utah AAPC Poison Control recommends hospitals stock 1 vial of black widow antivenom, and patients have gotten up to 3 vials of antivenom. So that's basically the treatment for black widow envenomation. Important to remember that with black widow envenomations, you can have a recurrence of pain 1 to 2 weeks later, or pain that persists for up to 2 weeks after the bite. So they're gnarly little animals. They do their thing. So moving up the chain, we've gone from spiders. Now we're going to talk about the scorpion. It's surprising how many scorpion envenomations there are throughout the United States. These guys, and the one medically important scorpion envenomation is the bark scorpion, which is seen here. The money end, of course, being the stinger. The point of that stinger is called the telson. These things are built to deliver venom. The pedipalps are basically used for holding its prey. So it holds its prey, stings it, the creature dies, and the scorpion eats. These are amazing animals because they breed like crazy when times are good, and when the food source is lacking, they just eat each other. So they perpetuate themselves, It's really interesting. So they can't sting multiple times. Typically the first sting will deplete the venom. The bark scorpion is a pretty nonspecific looking creature. It's slender. It's brown or golden. It's got both a slender body and tail. We talked briefly about the big-bodied scorpions and the small stingers. In terms of the bark scorpion, it looks very slender throughout, so it doesn't really follow that rule. They're really good climbers. There's a lot of reports of patients sleeping at nights and their sheets fall into the ground a little bit, and the scorpion, enters into the bed that way. So that's one way to keep them off you at nights if you're living in a desert climber. If there's a lot of scorpions, is to just be aware that they do climb well and try to prevent that as much as you can. So for Utah, in the last 3 years, 320 reported scorpion bites. And that might be a little bit more accurate. I think if someone gets bit by a scorpion, again, the mysticism and folklore of scorpion bites would probably make most people want to seek care. And so you as a clinician are going to have to decide, is this a serious scorpion bite, or is this one of many other scorpions that are not bark scorpions that have no real medical significance other than maybe some local pain, maybe like a hornet sting. This map shows a little bit of the regions in which bark scorpions live. And as you go farther south, you're going to find a lot more scorpions. But really, the bark scorpion is the one in our country that gives us medical problems. There it is again, that telson, just totally built to deliver venom. Very effective venom delivery apparatus, this creature. So we talk about rapid onset localized burning pain with, again, minimal local tissue destruction. They talk about a tap test, which is where you tap the portal of entry, wherever that might be, the injury site, and it causes much worse pain. And some clinicians, feel that that's a real good indicator that this truly was a scorpion bite using this tap test. Something to think about. Again, lots of neurotoxicity here, lots of systemic effects, not a lot of local. Fasciculations, paresthesias, hyperexcitability, abdominal pain, and abnormal eye movements being some of the most common. And then they also get this cholinergic syndrome, kind of similar to the black widow spider bite. Let's talk about the treatment for bark scorpion. No widely standard care exists. This is all about supportive care. The literature, the authorities talk about several hours of observation to monitor for neurologic, respiratory, and cardiovascular effects. In young kids, sometimes they need respiratory support because of the hypersalivation that results. And then there's lots of different treatments. It's, again, all symptomatic. If they're hypertensive, bring that down. If they're hypotensive, help support their blood pressure, help support decrease secretions with the use of atropine. Local and systemic analgesia, muscle relaxation. A lot of clinicians in Arizona who treat lots of scorpion envenomations will digitally block or block the extremity that was bitten to help with pain control. Pain control being a major issue for the long term, for up to 2 weeks with scorpion bites as well. And then managing airway and secretions, especially in children. Now, this is interesting because this antivenom has been very effective. It's a goat-derived antivenom. It's non-FDA approved, and it's no longer in production. It's been very effective in reversing neurologic, respiratory, and cardiovascular toxicity. There have been 2 deaths in the last 20 or 30 years with scorpion bites, with bark scorpion. One was, and they were both related to allergic reactions. One was anaphylaxis, thought to be from the antivenom, from a child that lived on a farm where there were goats. And so it was felt like this patient was probably sensitized to the goat antigens in the venom. And the second child had an anaphylactoid reaction when bitten by the bark scorpion. So they both were a little uncommon. It's not the venom itself so much that kills, but maybe the allergic response that can result. There are some trials currently underway, and if you really need to get some antivenom, and this is in your handout, Poison Control of Tucson, where this is a much bigger issue for them in the South. They have current guidelines and antivenom availability. I know it's available in Tucson as well as Las Vegas. So something to consider if you really felt you needed help or needed to get antivenom to a patient in need. So I think, just taking a break here as we move on to the bigger creatures, you can become a real star here in your differential. For a patient that comes in, this is the classic child that isn't acting right, maybe has a little mark on a digit or a toe. What is going on? In fact, the literature talks about in the south, in Arizona, in some of the high deserts where meth labs are very common, you have black widows, you have methamphetamine problems, you have scorpion bites. They all kind of look alike, right? So this could make you a real star in treating your patients. Think about widow spider bites, absence of local effects, lots of hyperirritability. Absence of hyperirritability, lack of local effects, but lots of muscular pain, lots of systemic effects. The classic symptom for widow bites is muscle pain. Organophosphate poisoning also looks very similar to, or can look similar to, widow and scorpion bites. Think about that in terms of the history and the circumstance surrounding. And then scorpion, widow, and methamphetamine use. You know, this hopefully will be indicative with a tox screen being helpful, looking at the history and circumstance. Obviously, shouldn't have any pain or paresthesias. Some patients apparently have claimed to have been bitten by a scorpion bite when in fact they've been using methamphetamines. So something to consider. Let's talk about the next greatest envenomation creature. And here I have 3 pictures of really colorful snakes. And you know, we're not really in the geographic region for this creature. We are for the non-venomous types, but it's still important to realize that one of these 3 is highly venomous. And that would be this guy right here, which is in the elapid family, or coral snake. And coral snakes, the dictum to remember, if you haven't heard this already, red on yellow, kill a fellow, red on black, venom lack. And you can see these wonderful colorations with red on yellow identifying the coral snake in this country. That's a really solid way to identify the coral snake versus milk snakes and king snakes, which use mimicry to try to scare off potential predators who might prey on them, looking like the dangerous coral snake. And you can see here the range of U.S. coral snakes are a little bit out of our range unless you're talking Arizona or traveling. Let me go back one really quick here. As you go farther to the east in our country, the venom, it becomes more and more toxic. So the eastern coral snake found in Florida is much more venomous than the Arizona coral snake. In fact, there hasn't been much problem with the Arizona coral snake whatsoever. Very little problem because they burrow. They're smaller snakes. They're very very solitary animals. So there's not a lot to report really on Arizona coral snake treatment because it just doesn't happen that often. Again, in your handouts, if you ever feel there's a question or if you come across this, the Arizona Poison Control Center is all on top of this. They're no longer making coral snake in this country than coral snake antivenom, but it is available through Mexico, where it's a much greater problem. So let's move on to the greatest of all envenomations that we will all face, and that's of viper or rattlesnake envenomations. And I just want to start to make sure that we all can identify these creatures. Here we have 2 heads, and the hallmark finding is this triangular-shaped head. It's not 100%. It's not 100%, but fairly accurate. Very narrow neck, very big triangular head. More accurate, though, is the eye structure. And when you see these elliptical eyes, these cat eyes, that's probably the best marker. There's some other markers, but you don't want to be handling the snake. They talk about looking at the underside of the snake, looking at its anus. I would prefer really not to look at the snake's anus. I think I'll just look at its eye from afar. So I want you to remember the elliptical eye, the triangular head. Now rattles are tricky as well because baby rattlesnakes are going to have a little button. They will not have a rattle. So don't be fooled with rattleless rattlesnakes. This shows a little bit of the distribution of vipers in the United States. Again, Alaska might be a good place to move if these things bother you greatly. I've chosen a few important snakes to just show their region. The Mojave Rattlesnake occupies Arizona, California, Nevada, the southeastern tip of Utah. These rattlesnakes have a lot of neurotoxicity. which is fairly unique among the rattlesnakes. 90% of rattlesnake envenomations will cause a lot of local damage. You can see the western diamondback distribution there centrally on this slide. And lastly, the western rattlesnake. The western rattlesnake is kind of a grab bag for many subspecies of rattlesnakes. And the one that's really important of interest for us medically is the southern Pacific rattlesnake. And this is felt to have very high neurotoxicity as well as local effects. There's some feeling that maybe the western diamondback and Mojave rattlesnakes kind of got together and did some hybridization, crossbreeding, which created this kind of super snake, which is this southern Pacific rattlesnake. And when we talk a little bit about treatment as well, the southern Pacific is a little trickier to treat because it doesn't respond as well to the antivenom therapy. And this slide here, I don't know how accurate this is. There's so many websites on snakes. There's a lot of herpetologists that know so much more than I do, but this gives you an idea of the distribution of reported venomous bites. And you can see that copperheads and cottonmouths or water moccasins, they bite a lot of people, and I think it's mainly because of the population densities. There's a lot more contact with copperheads and cottonmouths with people in the southern reaches. Unfortunately, these two, among rattlesnakes, their venom is not the most dangerous of venoms. People do very well after copperhead and cottonmouth envenomations. They also don't have rattles, in case you're traveling back south, but they look very classic, like the viper. And so I've been alluding again and again about both potency of venom and the delivery of the venom. And for rattlesnakes, they score high on both ends. They have a great delivery apparatus for delivering venom, these retractable fangs and large venom glands. And when we think about a snake bite, we think about the depth of envenomation, again, thick, glabrous skin versus maybe some thin skin, the size of the snake. There's been a lot of discussion about smaller snakes having more potent venom. Doesn't matter so much, but the size of the snake will certainly impact the volume of venom that they can deliver. The number of strikes. You don't have to catch the snake. You get bit once, probably good to move away, get away. And then lastly, the location, the airway and vascular considerations for rattlesnake envenomation. Now, I live right next to Camp Pendleton in San Clemente, California, and this is a quote from a little 2-year-old girl. "I made a mistake and kissed a snake." She must have been watching too much Disney. So this is her on day 1. She was bit on the right, kind of right at the corner of the lip there. You can see just the intense swelling here. She was intubated prophylactically before her airway was completely gone. Tensely swollen. Looks very, very damaging. 2 weeks later, she's now extubated, still in the hospital. You can see how the local effects are resolving here. You can see that kind of marbled green-brown hemorrhage, ecchymotic area that's slowly being resorbed. And then this is 6 months later. She's cute and looks great. And this is a function of Crowfab, of antivenom. And we're going to spend the remaining 15 minutes or so talking about indications for Crowfab. For the first time, the snake wranglers, herpetologists have gotten together in February of this year and had a consensus workshop. And this is in your handout as well. So what you're getting today is the first ever updated version of how to treat rattlesnake envenomation. So they talk about 3 things to look for in rattlesnake envenomation. The first and most obvious would be local tissue effects. I think if any of us saw this, we would say, yeah, this is something happened here. This is not a dry bite. You can see a lot of hemorrhage into the leg here and swelling. So proteolytic enzymes found in almost all snake venom, regardless of which subspecies, causes lots of soft tissue necrosis, inflammation. So first, the venom creates intense inflammation, and once that starts, our body's immune system, that immune cascade gets triggered, which recruits more and more inflammation, more swelling. Your body's desperately trying to contain this venom, trying to wall it off, and usually has a really hard time doing that. Clinical effects locally, obviously going to feel a lot of pain, swelling, erythema. You can see a lot of lymphangitic spread that might make you feel like this is more of an infectious process, but again, the history should be very telling. bullae, where the skin gets full of hemorrhagic fluid, ecchymosis, and then also myonecrosis. So this a rattlesnake bite is hardly ever going to be able to be deep enough to enter the muscle compartment. But these proteolytic enzymes will, unlike the recluse spider, they will degrade into the fascia of muscles and involve muscle compartments, causing myonecrosis. So local effects being number one. Number two is hematologic effects, both pro and anticoagulant responses to venom, and these can be delayed and reoccur. I think that previous slide showed some of the hematologic effects. You're going to see oozing from the blood side, or from the bite side, the ecchymosis and the edema that these anticoagulant effects cause are going to worsen the local effects. Everything's kind of combining against that extremity to create a lot of tense swelling and a lot of compromise. We talk about loss of fibrinogen, your platelet count plummets, and your prothrombin time will be elevated. Some practitioners use fibrin split products as an indicator of an envenomation. And if you feel confident you could do that, it's certainly not something that you would follow serially. It's either positive or not. If it's positive, think envenomation, think a true wet bite. But really the big three that we're going to follow are fibrinogen levels, platelet levels, and prothrombin time. Untreated, again, your body's trying desperately to wall off these toxic venoms. Untreated, all of the coag factors are depleted, your platelet count plummets, and you have consumptive coagulopathy. And outside of this country, in India and Africa, where they don't have many tools, they'll actually take a patient's blood and put it in a vial and wait for 20 minutes, and if it doesn't clot, then they know that this patient still has consumptive coagulopathy. That's how they test for what we do here with platelet counts and prothrombin times. So that would be a field way to do it, but luckily we don't have to do it that way. So local effects, hematologic effects, systemic effects. The two big snakes that we worry about, the two big vipers, being the Mojave and the southern Pacific rattlesnake, causing systemic effects. Neurotoxins and cardiotoxins are the name given to these venoms. We talk about fasciculations, nausea, vomiting, unstable vital signs, paralysis, respiratory failure, angioedema, and then some taste disturbances, all related to these neurotoxins. This slide here shows a patient 20 hours after being envenomated to the hand, and you can see he's got some local effects, probably some hematologic effects, but he also was having swelling up into his chest and neck, which made these clinicians feel like he needed to be intubated, and so that's why he was intubated. The systemic effects for rattlesnake envenomations do not kill unless we talk about a big vascular area. For some reason there was an intravascular envenomation or something around the airway. Obviously, in the case of our little girl, that's something you want to take care of right away, is make sure that we do not have an airway problem. So let's talk a little bit about pre-hospital considerations. There's not a lot here. Best first aid tools, and Dr. Heilson and I were involved with a few of these studies. We studied the extractor device, which is still on the market today, this great thing. You're supposed to put it on the snake bite lesion, and you're supposed to suck, and it sucks out the venom. And then, cut and suck. It's still, and if you go on these websites of these herpetologists, it's still everywhere. There's so much voodoo out there about snake envenomations. It's your job to help the public realize that none of that works. It only makes it worse. There's been tourniqueting of the extremity and shock therapy and ice. And it really just delays definitive care, and it could make it worse. So the best tool, and for you scout leaders out there, you need a good satellite phone that works wherever you are. That's your best first aid tool. Call 911. Time is tissue. We're talking about the local effects. The local effects for snake envenomation. The quicker they can get to antivenom, the more likely they're going to have a usable finger or toe or extremity. You can try, if there's a long extrication from wherever you might be, you elevate, you immobilize the affected limb, rest the patient, but no tourniquets, no cutting, sucking, antibiotics, ice, NSAIDs. All of that just delays definitive care. No snake wrangling. You could take a picture, but don't send the the Girl Scout troop out to try to catch the snake. That would be bad. We don't need to know. There's not too many snakes to choose from around here. They're all rattlers. So hospital considerations. When they land at your door, at your clinic, at your ER, no-brainer would be addressing the ABCs first. And think about the non-treatments that were attempted. So the one big one here that's important, I think, is if the patient comes in with a tourniquet on the extremity, you're going to see this, guaranteed. It's so prevalent in the lay press. You know, tourniquet the limb. You don't want to get the venom to the heart. So they come in with a tourniquet. What do? Well, you don't release the tourniquet until you're ready to deal with the toxic effects of the envenomation, which would be, you know, having 2 large bore IVs prepared, having airway materials there. I think the tourniquet is the one thing to think about as clinicians when you see these patients, that we're ready to address that. And calling poison control. So there's a lot of good reasons. Poison control is completely set up to help you as an additional provider with these patients. It gives you medical legal security. You know you're following up-to-date standards. They actually will follow the patients through till hospital discharge, which is very comforting to know. It will help the inpatient service. And just all around can be very comforting when you're wondering what steps to take, or if you've lost your clinician's reference that you have today. And then observing for the big 3, okay? They're in your care now. You're observing for the big 3, right? The big 3 being local effects, hematologic effects, and systemic effects of envenomation. This is a good touch, too, is to prepare for any sort of allergic reaction that might take place, either from the snake bite or from the antivenom that you plan to deliver. So this is a picture showing how to monitor your local effects. So this patient was bit there on the 5th toe, and typically they talk about finding the most distal fang mark and measuring proximally the line of erythema, as well as making circumferential measurements. And we're looking for progressive local effects by doing so. And you can see here that this patient has it actually marked and timed as to what time, you know, to try to gauge the advancing venom effects. Hematologic, fibrinogen, prothrombin, platelets. Just those 3. Pretty simple, pretty straightforward. You're thinking about looking for hematologic effects. And lastly, systemic effects. Think about hypotension, systemic bleeding, fasciculations. So now we're going to talk about Crowfab briefly before we jump back into the clinical piece. Crowfab's been here since 2001. Very safe antivenom compared to the Wyeth antivenom, and because the reason it's so safe is because of the breaking apart of the antibody. So the disulfide bridge, which takes away the Fab fragment from the FC portion, allows us to not have the FC portion, which is the effector portion which activates the entire immune cascade, if you remember from your immunology classes. The Fab fragment is what's going to deactivate the venom. That's the money piece. We don't need the FC portion. And so today's Crowfab, or today's Viper antivenom, is a Fab product, which is wonderful. Very few acute allergic reactions to this. There's still about a 5 or 10% type 3 allergic hypersensitivity, which happens later, which is like a serum sickness with rash, arthralgias, not a big deal. So very safe. The Crowfab comes in this kind of box here with 2 vials. It's about $4,000. It's 36-month shelf life. And again, the poison control centers have recommendations for our hospitals on how much should be stocked. Production of the Crowfab begins with it's ovine derived from sheep, and they've used 4 different types of rattlesnakes: Western Diamondback and Eastern Diamondback, Cottonmouth, and then the Mojave. The Mojave in an attempt to get some of the neurotoxic effect that we're looking for in antivenom. And here's a bad picture of someone milking a rattlesnake. I wouldn't recommend doing this at home. So back to our hospital considerations. Crowfab. It's all about Crowfab. Reduces local, hematologic, and systemic effects of envenomation. And to get it on board sooner rather than later will help significantly with the local effects. Crowfab is not indicated in a dry bite, which happens 20% of the time. and non-progressive localized pain. So this is a little tricky. This is the one kind of clinical piece that you have to make judgment on. Is this just a local bite, there's local pain, swelling, erythema, or is this progressive localized bite? For me, for the snake bites I've seen, I typically check their blood work and monitor for 4 hours. If I don't see advanced localized effects and if their blood work is normal, regardless if there's fang marks, then they go home. Conversely, they can have no fang marks. They can be very difficult to see. They can have no fang marks and still be envenomated because these fangs are very small, very sharp. They're not going to leave a lot of local or not a lot of effects right at the bite site. So that can be a little tricky. So think about that when Crowfab is not indicated. But it is indicated with any systemic effects, any hematologic effects, and for progressive local effects, the big three. Now, the consensus workshop group came up with these two arms. There's initial control versus maintenance. Initial control is looking for a targeted response. Basically, they were looking for the local effects to be arrested, a clear trend towards improvement of hematologic effects so that the coag parameters and platelet count, fibrinogen levels are all improving, and then resolution of all systemic venom effects. Until you have those three, then you're still on initial control. You're still trying to control the effects of venom from the start, okay? You're not into maintenance until the initial control is there, which requires all three to be under control. So the initial dose, typically 4 to 6 vials of Crowfab given over 1 hour, and then you wait an hour. You reevaluate for the big three, and then you can give further Crowfab as indicated. And then once your initial control is achieved, this is important so that you could say, okay, initial control achieved, and now the clock starts for an 18 to 24-hour observation period. And during that 18 to 24 hours, you begin maintenance dosing. Sorry, I just had to remind you one more time, the big three for snake envenomations. So maintenance dosing minimizes recurrence of envenomation. Some practitioners who are very savvy, who have seen a lot of envenomations, might just do PRN dosing. But this requires a lot of watching, observation. You kind of have to, you're kind of out there on your own if you choose to do that. If you follow maintenance dosing, again, you're within the consensus workshop group, you're within the standards, and you're safe. So the maintenance dosing is 2 vials every 6 hours, total of 3. So 6 more vials once you've achieved initial control. Follow-up labs in 6 to 12 hours. Again, once you've set that clock for initial control, once that's taken place, the clock begins for both observation and for the time when you're going to recheck some blood work. And this little graph here, this is from the product manufacturer of Crowfab. They really recommend the scheduled maintenance dosing over the PRN dosing because you get such a better response both from the hematologic side of things and from local effects. So I think that makes a lot of sense. I mean, at this point, you've spent a lot of money on Crowfab, and by delaying, you're going to spend more hospital days and possibly have more complications. And really, with rattlesnake envenomations, we're talking about regaining the function of the extremities. The extremities is what we're looking at: fingers, toes, and we want to get those back working. And then the post-discharge instructions, pretty straightforward. Watching for worsening local effects or abnormal bleeding. Think about serum sickness. Bleeding precautions for 2 weeks. No contact sports or invasive procedures for 2 weeks. And then for those who have received antivenom, they talk about follow-up on day 3 and day 7 for blood work and just a routine check. Now this is, let's go full circle. Our time is up. Our full circle here is when do we do invasive procedures and when do we just change underpants? The patients 10 years ago were all getting, or many of them were getting fasciotomies for what was thought to be compartment syndrome. And this is a message I hope that you will take home today, that there's very, very few indications for fasciotomy in snake envenomation. This happened to be a drunk person who found a snake in his backyard, was bit on the finger, was admitted, ended up getting fasciotomies and dermotomies These are major surgical procedures, lots of time in the hospital, lots of complications. And the reality is that local envenomation does mimic compartment syndrome, but it's not true compartment syndrome in the sense that compartment syndrome comes from crush injury literature. These are patients that get crushed. The pathophysiology is very different. Crowfab is going to be the treatment of choice again for patients that look like they have compartment syndrome or who have elevated compartment pressures. Only time to really consider fasciotomy or digital dermotomy is if you've managed the big three and you have true compartment pressure elevation, which would be 30 to 40 millimeters mercury elevation within the muscle bellies. And this is important to know. I think our surgery colleagues would be fairly quick to go to fasciotomy when they see the presentation. It really does mimic compartment syndrome. And so we need to make sure we spread that word, that correct way to treat this, being more Crowfab. And again, the Crowfab indications. So I hope you feel like you've all become empowered as envenomation specialists. There's not that much to know, but you know a lot more than the vast majority of clinicians and certainly the lay public, and I thank you for your time.
Given the late hour, is there are there one or two questions for Dr. Hegewald? Yes, sir.
Say that one more time. The question is the antivenom given IV? Yes, that's correct. And when you first start giving antivenom, the first 10, 20 minutes are a slow drip, looking for anaphylactoid type reactions. And then you would give it over an hour. The initial control, 4 to 6 vials over the first hour. Good question. No, it has to be reconstituted, but it's straightforward. The pharmacies usually do that for you. Yes? The question is, do hobo spiders do dry bites? I don't know. Does anyone know? Where was the bite located? What part of the world? Here in Utah. Okay. And you were able to identify it, huh? And no local effects. Well, lucky you. That's good. Yeah. Smart spider. Knew he couldn't eat you, so he didn't give you any venom.
Oh, yeah, I have plenty.
Yes, right here. The question is, are there any special conditions for storage of the venom? It comes in a dry powder form. It has a 36-month shelf life, no special conditions. I'm sure you're not supposed to freeze it or boil it, but other than that, it's just like any other dry powdered medication. Hope that helps.
Thank you.
Okay, thank you. Thanks, Tyler.
The meeting is adjourned. We'll see everyone tomorrow morning at 7 a.m. And again, if you don't find parking, go over to the junction. It's free over there. Thanks.